Okay. So time is short, so I guess I'll start right away. How's the mic working? Okay, great. Okay, so today I'd like to talk about race and risk in medicine, and particularly public health. And so what I'd like to do is to try to sort of draw attention to a particular problem of the use of race in medicine that as far as I understand it, this work is very tentative for me, this is very new. As far as I can tell, it's been sort of underexplored, which is the problems that are raised, particularly when you have a large racial category that's been identified as having higher risk for some particular disease, but within that category, there are essentially islands of low risk, subpopulations that are identifiable but do not have the same level of risk. And because I think there are special issues that arise from that. So just sort of review, there's a special issue of the Journal of Law, Medicine, and Ethics that talks about the sort of standard race and medicine debate. And I think Troy Duster, an important sociologist of race, sort of lays it out pretty well. He says, well, the unenviable task has been to try to walk a tightrope, to figure out a way to effectively deploy in research the concept of race or population groups designated by race without endowing race with a false sense of genetic essentialism. And so one of the things that he's most worried about is this concern that when public health officials, particularly, but anyone early in medicine, when they use some sort of heuristic or tool, such as a racial category, they're just using it because it works. And they don't necessarily care about the ultimate meaning behind it. They're not necessarily race realists, as the term sometimes goes. But when that information is passed across to the public, directly or indirectly, or even to other members of the scientific community, they could falsely infer that it means more than it actually does. And so there's the risk of accidentally imbuing race with more biological meaning and medical meaning than it actually has, which has negative repercussions for interpretations of how different we are as human beings. The argument for using it, though, is laid out by Jay Cohn, an important empirical worker in sort of population phenomena of cardiology. He says, well, diseases do show different prevalence and treatment responsiveness in populations defined by race. You can statistically find these correlations. Now is concerned about throwing out the baby with the bathwater, which is a very legitimate concern. So if you take, for example, sickle cell anemia screening in the United States. So if you do sort of a population study of rates of sickle cell anemia within the United States, the rates will be much, much higher in African Americans compared to Caucasian Americans if you divide them that way. And there are biological reasons for that, although they're not necessarily racial ones. So sickle cell anemia, as most of you probably know, it essentially co-evolved with the malaria pathogen, such that having one copy and being asymptomatic of sickle cell anemia makes you resistant to malaria. And so those who have ancestors who were in basically malaria-heavy areas, more likely to have sickle cell anemia. And so there is a way of profitably discovering that. And so if we were to essentially create race-blind sickle cell anemia screening programs, then we would essentially be losing a useful tool for trying to identify high-risk populations. And that would be essentially harmful. And so that would be a problem. On the other hand, though, you have Mildred Cho, a sort of cross-trained bioethicist and pharmacologist, who says there is no baby in the bathwater, that we would not be losing that much by abandoning race in this context, because, for example, those sickle cell anemia programs focusing so heavily on African Americans have, for example, ignored Greek Americans, who also have increased risk of sickle cell anemia. And so the fuzziness makes these categories essentially untenable. And so it wouldn't be like losing the baby in the bathwater, it's more like losing the rubber ducky or something like that. And so I'd like to talk about two particular examples, two particular phenomena that have been extremely well studied over many decades and have been well established. And one is that if you divide them up that way, African Americans have much higher rates of hypertension than non-Hispanic whites. It's about 30% higher for men and about 45% higher for women. Hypertension is bad, causes all sorts of nasty things like strokes and damage to your tissues and such. And so this is amply demonstrated that there is this correlation. There's also a correlation between Caucasian or European ancestry and rates of cystic fibrosis. So Caucasians or European descendants, different journals will use different terminology, so it's a bit of a mess, so you have to sort of bear with me with this. The rates are around one birth in every 2,000 to 3,000 births. And if you sort of take another couple of populations out of a hat, as I sort of did, that's about 7 times the rate in Mexico, or about 56 times the rate in India. So this is a group that is at far higher risk and hence is prima facie a very good target for essentially high risk screening programs. But there are problems with actually defining these groups. And so Reed et al. Have a wonderful paper in 2005 saying that, well, everybody knows about this black-white health disparity. It's probably one of the phenomena that's been most widely studied by pretty much every single academic discipline, including even the fine arts. But that actually conceals a great deal of heterogeneity in the health status of Black Americans. And so if we look only at the averages, we miss the complexities of what's inside those averages. So, for example, there are enormous differences between essentially the health profiles of northern African Americans compared to southern ones. Even more so, there's enormous differences introduced if you look at African immigrants, who become essentially African Americans once they get here, but have quite different experiences. A similar problem arises in cystic fibrosis. So Lindy and Mueller have this really nice history paper that's just very recently. And they talk about essentially the failures of the cystic fibrosis research and all the promises it made that it didn't keep, saying that it's poorly understood and linked in complex ways to race and to European identity, but it's a bit of a mess, and it may be the canary in the coal mine saying that there is no future in genetic medicine. Maybe a bit far, but it's a good point. So if we look at how these racial categories and these risk groups are identified in the literature that's actually being passed around to people, well, we can see that, like in the dietary guidelines handed out to essentially all Americans in 2010, these are the current guidelines, as a joint thing from the USDA and the Health and Human Services. And so they're responding to essentially that Americans eat way too much salt. Partially, I mean, we also eat a lot too much fat, and we also eat too much. But they recommend low-sodium diets for everybody in America, at least compared to what we're eating now. But there are two tiers. There's the very low-sodium diet and the very, very low-sodium diet. The very low-sodium diet is for pretty much everybody unless you have one of their risk factors. Those risk factors, though, would essentially trigger you getting the very, very low-sodium diet. And those risk factors include being diabetic, already being hypertensive for obvious reasons, having chronic kidney disease, and African Americanness. And so here we have Troy Duster's concern of, well, what if we accidentally imbue these racial categories with an essentialism that's really not appropriate? And so it's possible that we could try to justify that use if there is very good reason for it, if that's actually accurate, for example, or if it's somehow beneficent. And so the question is, well, is African Americanness a risk factor for hypertension? Does African Americanness mean you should eat less salt? Well, yes and no. No, because if you look at African immigrants, well, foreign-born non-Hispanic blacks have about 47% lower rates of hypertension than US-born blacks. The relative risk of mortality from cardiovascular disease, if you adjust for income, age, etc., it's over 50% lower among African immigrants than it is among US-born African Americans, and it's even lower than US-born non-Hispanic whites. Even, this is interesting to me, even among those who do have hypertension, African immigrants fare a lot better than US-born African Americans. So women have approximately 68 to 78% lower rates of end organ damage, essentially tissue damage from hypertension. And men have about 14 to 39% lower rates. Those variations are if you compare northern or southern African Americans. So we have, so in that case, we have essentially an island of extremely low risk compared to the high risk racial category. And before I get into the problems of that, I want to, went too far back. I want to look at my other example first, which is Finnish ancestry and cystic fibrosis. So as I was sort of working on this project, which is still very new, but I realized partway through that I was doing something a little bit unusual. I was going to make the case that that racial categories can be used in a harmful way, but I was actually going to make the point partially about white people, which is not the way that usually goes. And so actually I think white people can be harmed by, by misuses of race in medicine too, although it's not where we usually put our attention, nor should it be really. So cystic fibrosis, it's a recessive genetic disease. It's pretty much invariably lethal. Only very recently is it actually possible to live into adulthood with the disease. It causes lung dysfunction and pancreas dysfunction. It's very complicated. It's just a very terrible disease. And as Lindy and Mueller again say, it's often characterized as a white disease, although it occurs in many populations, but still much higher among white people, as I said before. But is it actually a white disease? Sort of. People of Finnish ancestry have cystic fibrosis rates of around 1 in every 26,500. If you remember from before, that's about 10 times lower than Caucasians in general. So again, we have another low-risk island inside the sort of sea of higher-risk race or something like that. And so what interests me is, well, how is the world of public health responding to that? How is the medical literature responding to this sort of interesting subpopulation that doesn't have the same problem? So here's a committee opinion from the American College of Obstetricians and Gynecologists. Essentially, this is the advice being handed down to obstetricians and gynecologists. So they give their table, and you'll see these everywhere in the cystic fibrosis literature. Well, the risk of being a carrier, being an asymptomatic heterozygote of cystic fibrosis, if you're a non-Hispanic white, it's 1 in 25. What they don't mention anywhere inside their committee opinion is Finns. They don't appear anywhere, when in fact the carrier risk for Finns is 1 in every 77. So it's a 3 times lower carrier rate, 10 times lower disease rate. And sort of the exception that proves the rule in my mind about the way this has been maybe not used as well as it could be. If you look at a similar statement, you might not be able to see it now, from the National Society of Genetic Counselors, it actually mentions Finland, saying how, oh, there's quite a range of different rates among different populations. Here's Finland, here's another population, yada, yada, yada. Here's the rate for non-Hispanic whites. They don't make anything of it. But I think this is actually really important because I think by lumping them in, I think there's genuine harm being done. But the problem I have to deal with here, or at least the one that I've sort of identified as a potential problem, is, well, everybody benefits from cystic fibrosis screening. Finns get it too. African immigrants get clinical hypertension too. Everybody benefits from a low-sodium diet. What's possibly wrong with this? And I think the root of the problem ultimately comes down to that these guidelines, they were written without taking these subpopulations' interests into account. I don't see any indication at all that anybody really gave a crap about African immigrants or Finns when they were writing these things. And that is an imprecision that's problematic. And so some of the problems that arise are, for example, you have behavioral expectations not being based on the relevant risk data that's available. So the scientific world knows that Finns have low risk of cystic fibrosis, far lower than most Caucasians, far lower than many other populations. But if you take, for example, a hypothetical Finnish couple, they both are from Finnish ancestry, that walk into their family physician's office, say, we're thinking about conceiving, we're thinking about getting some genetic testing first because I know that's kind of a standard thing. Should we get carrier testing for anything? Well, the physician, having been told that Caucasians are at high risk, would say, well, you're both Caucasians, so maybe you should think about cystic fibrosis testing. It's pretty high frequency in your population, and so maybe you should think about doing that. You should expend your resources on this. And so the expectations that are being driven by the medical community, that are being even driven by society, when you hear about the local, when you hear that there's Cystic Fibrosis Awareness Day inside your community, the expectations about your behavior are not going to be based upon the data that's available. They are not being told the data that they are low risk. And so that creates resource burdens. It creates them on the couple, who now are going to be more likely to spend their money on a testing program that would not be especially useful for them, or at least their cost-benefit analysis would not include the actual relevant data. And whenever we have misuses of precision or of data within public health, we also cause harm to society too. And so it is harmful to our society because we could be spending that money on something more profitable. We could be using that money that's essentially directly or indirectly going into cystic fibrosis testing. That particular Finnish couple, that could be better spent somewhere else, or at least we should have a conversation about whether or not that's the way we should be spending that money. And there's a bit of a zero sum always with public health. It's not like we have too much money going into public health. And we still have this problem of the promotion of harmful biological essentialism of race. And so by suppressing the existence of these low-risk subpopulations, essentially shrouding out these islands, then we are reaffirming and reinforcing in a way that we know to be false. We in sort of the scientific community who now know about this stuff, we are reaffirming and reinforcing the existence of deep divisions between human races, when in fact the data is not bearing that out. We have a wealth of contrary data in both cases. And there's also this other problem that sort of occurred to me later on as I was working on this. I'm not sure what it says about me, but when I was about 2/3 through this, it's like, oh, what about the truth? Should we be telling the truth here? And so I think I've made the case that we are misleading Finns and African immigrants right now. That there is a failure, or at least an imperfect case of truth-telling here, to not use the L word. But the thing is, I'm not going to go on record as being opposed to all failures of truth-telling or failures of openness in public health, because I think there is at least the potential possible use of that in a profitable way. So vaccination programs, for example, when you go into your doctor and they're telling you why you should get a flu vaccine, they might emphasize to you that, well, you could miss work if you don't get if you don't get the flu vaccine, you catch the flu. It could be very unpleasant. You should get a flu vaccine. Actually, one of the main motivations for trying to push people to get flu vaccines is so that they don't accidentally kill their immune-compromised cousin, or it's their elderly grandparent or something like that, people who would be more harmed from a flu infection than other people. And so I'm not really entirely opposed to not really mentioning that in the pamphlets or not emphasizing it in the doctor's office. There's at least a case to be made for why that openness would not be productive, because it might lower the vaccination rates, and we drop below herd immunity and everything goes to crap. But in the case of these two examples, the misleading risk information that's being passed along to African immigrants and Finns, I don't see any justification for it. Why do we have to not tell them the truth? And I can't figure it out. There's no overriding reason of beneficence or of non-maleficence or something. I'm just not seeing it. And so what I really didn't mean the alliteration. What I see here is a case of a heuristic that's essentially become hegemonic. It is these racial categories are eating up more precise categories when we should be using more precise ones. They are essentially impeding us from being more scientific, if we want to sort of use the capital S scientific, because we have data that could be usable, that's perfectly acceptable, and we are neglecting it for reasons that I can't understand, other than perhaps the fact that we are really terrible about dealing with race in the United States, at least maybe in the entire world, I don't know. And so that's a genuine problem. And so I think this sort of adds another wrinkle to our sort of discussion about, well, can we and should we use race in medicine, and especially in public health? Yes, it helps us to identify Caucasians who are at higher risk. It helps us to identify African Americans who are at higher risk, but it also suppresses information at the same time. And so that sort of dual benefits and burdens issue sort of complicates the issue in my mind as far as whether or not we should use race in medicine. But at the very least, we can start by making a couple of changes, and I think they'd be sort of shockingly easy. So those of any age who are US-born, African-American, non-Hispanic, non-Finnish whites have a carrier risk of 1 in every 25. Small problem is solved that way. The bigger problem of can we actually responsibly use race in public health? I'm pessimistically optimistic. Thank you.
So my name is Andrea Smith. I'm coming to you from Hamilton, Ontario, where I'm a PhD student in health policy at McMaster University. And there we go. So the title of my talk is that there are values in my evidence. And I want to talk a little bit about my PhD research on the normative dimensions of gene-environment interaction research, or GXE research, on asthma and their implications for policy. I'm going to start with my sort of take-home message, so if you want to sleep or go catch the other talk, if it's not of interest, feel free to do so. So in the interest of linking values, science, and policy, I think it's pretty clear that health research embodies both facts and values. So I start with the rejection of the fact-value distinction in essence. And that I'm focusing on values as being a very specific term that I will elaborate on. So values as evidence, values in evidence, that they can shape policy through problem definition and agenda setting. So two very specific policy mechanisms. And I want to try to make a case today very briefly that the concept of framing, as drawing from the social science literature, and qualitative research are posed as fruitful areas for exploring, linking the values and evidence to values and policy. And so as I mentioned, I'm coming from McMaster. And McMaster is said to be home, by many, of evidence-based medicine. And now, just these are some titles I grabbed from some books in the field. You may not be able to read them at the back, but it's evidence-based social work, evidence-based organizational behavior, evidence-based public health, evidence-based decision-making, and of course now we have evidence-based policy-making, or EBPM. And you know, of course, I don't have any objection to using evidence in policy-making. The question is, what is evidence and what's its constituting? And so I'm not going to get into that. But I think within policy making, there is the strong form of evidence-based policy making and the weaker version. And today I think engaging with the weaker form is more productive. So in its weaker form, evidence-based policy making admits that yes, there are such things as values, and yes, they're important for policy. The questions, though, are what are values and what are they not? So just to say one more point about evidence-based policy making is that it's very consistent with something that has been identified by Deborah Stone, who wrote a book called The Policy Paradox. An excellent work. I see some heads nodding. So she talks about the rationality project in policy. And it's this idea that we need to rescue public policy from the irrationalities and indignities of politics, hoping to conduct itself instead with rational, analytical, and scientific method. So we're not buying that. That's a strong form of evidence-based policy making. But again, what is the rightful place of values in policy? And so first, just what are values anyway? So in a researcher, my supervisor actually did a piece examining what policymakers in Ontario were using as values. And so they did a qualitative document analysis of all the different usages of the term values. And one thing that really came across was that decision makers and stakeholders in health policy appear to disagree fundamentally over what values essentially are. And so they go on to say that often values are seen as principles, values are seen as process, values are seen as collectively held, or values are individual preferences measured by willingness to pay. So this is diversity of values. And often without realizing it, stakeholders differ in their assumptions about where to look for values, how to know or understand values, and how values should guide action. So I think it's pretty important to start this by saying what I am meaning by values. So I'm using a very specific usage. I want to talk about values in evidence, values as they're embodied in scientific evidence. And so I'm using it to refer to the normative bounds of research inquiry. These are the normative bounds on the questions we ask and the way they are answered or perceived to be answered. What is considered proof or evidence? And importantly, what is left unanswered and unasked? This is in keeping with my reading of the philosophical literature around science as a social process. I'm not a philosopher, I'm in health policy, so I'm happy to engage with your ideas on these topics. But I think it's important to move us towards a non-individualistic account of values and evidence. And so to me, this means that values are social, that they arise out of and are shaped by knowledge-generating practices, and that values aren't reducible to individuals' cognition or preferences. I think we can be agnostic about individual values held by individuals. And so to me, this actually dovetails very nicely with what I mentioned earlier, this framing literature in the policy studies. Framing comes out of many disciplines: communication studies, policy studies, political science, and thus, like values, has many meanings. Just going to draw very quickly on two critical components. So this fellow Entman from communication studies tried to summarize what are the consistent aspects of framing across all of its usages. And he came up with this idea, which I concur with, this idea that frames are about selection and salience. So they are consistent with this idea of a social production of knowledge, that we select observations out of all possible observations, and then in a way that we construct our narrative of our observations and our interpretations based on salience, so what is persuasive about our particular organization. So again, what I think is helpful about framing when thinking about values is that it draws attention to the social construction of knowledge. Typically, the study of framing has been by looking at, through qualitative research methods, document analyses, these kinds of things, techniques to look at the bounds of narrative, so narrative analysis. And framing, I'm going to talk a little bit about asthma now finally, is important. Asthma researchers, social scientists have recognized the importance of framing. This is a website, so if you live near a Peabody coal plant, you can mail away to get a Justin Bieber puffer. And this is to help deal with the stigma of asthma. Right? So this is actually a spoof by an environmental activist group trying to draw attention to the role of coal burning energy production as contributing to asthma exacerbation. But it's a good example of the importance of framing in asthma. People have recognized that the questions we ask about air pollution in asthma, for example, are influenced by particular vested interests in society and institutions. But I want to focus a bit more concretely again on this idea of values and evidence. And rather than frames as being bounds, I want to use frames as scaffolds. And I want to talk about them as the constellation of concepts, methods, and evidence used to define and demonstrate causal relations in health research, and focusing on measurement as an important site and process in science where observation and values are constantly engaged. So I picked my interest in gene-environment interaction because of statements like this when I started looking at asthma. This is a prominent asthma researcher, Alan Becker in Canada, internationally renowned fellow, has done tons of work on primary prevention of asthma, getting vacuums into homes, trying to get out dust mites, and really has tried to, recognizes, right here he says, we recognize that we're going to need public policy changes at the societal level. Nevertheless, it's critical that we better understand the mechanisms by which gene-environment interaction influence the development of asthma. So I want to look at, I started by looking at the research on asthma and gene-environment interactions. This is my very briefly methods. I actually have done a document analysis. I have no idea what that text in the top left is, by the way. It's not there in my slides, I promise you. So just focusing on my research sphere, I collected policy sphere documents and I collected media documents, but today and interviews. I'm only reporting on results from my research sphere, where I collected documents using in Medline. I did in-depth interviews with researchers and actually observed some conferences and workshops of gene-environment interaction researchers and used rigorous sampling methods according to qualitative research standards. So the idea is identifying a purposeful sample of documents and then snowball sampling from there. So when researchers recommended a particular article, that would enter my sample through that. And I did an interpretive analysis in keeping with, sort of in keeping with Charmez, which is a grounded theory approach, whereby coding of the data were done at a line level, but then building codes on top of that across data and spheres. So I realize I'm running out of time, so I'm going to just jump to the findings here, so I'm cruising through. So I'm actually going to focus on the measurement of interaction and what researchers are talking about when they talk about gene-environment interaction. So there's two dominant frames are apparent in their conversations with me and in the literature. The first is this idea of a genetic predisposition plus environmental triggers. The second is an emphasis on biological pathways, so gene-environment interaction as a biological pathway and as a mechanism. There's overlap between these two themes, but there is some important differences that actually bear on the policy uptake of this research. So I'm going to start by reviewing this notion of gene-environment interaction as genetic predisposition plus an environmental trigger. And in fact, in the literature, they talk about this sometimes as gene by environment interaction, which really speaks to the statistical approach underlying this conception of interaction. This is often put forth by epidemiologists, and a 2x2 table is usually the way by which this is calculated. This is a diagram that is often cited in the literature, and researchers have mentioned it many times. It's not about gene-environment interactions per se, but it is about gene-environment interaction. It's a seminal paper from Ruth Ottman from 1990. These are different models of gene-environment interaction, all of which are tested statistically. So we're just going to walk through model C here, a very simple model. The notion of interaction is that you have a genotype, a fixed genotype that is time invariant, that is given to you, it's your DNA sequence, and that your risk of disease is dependent on whether or not you are or are not exposed to environmental risk factor. So the environmental risk factor is seen as being necessary but not sufficient for your risk of disease. And these are the types of findings that one sees in this research. So what you're looking at is on the bottom axis we have three different single nucleotide polymorphisms stratified by physical activity level and risk of asthma, adult onset asthma, over here. And so what the researchers here have done is they've looked at genetic variants by level of physical activity, and their conclusion is that physical activity actually masks the effects of genes on asthma. So it's this idea that, if we actually are, so what they're doing is they're treating environmental factors not as an explanatory variable in asthma, but as a confounder, confounding the relationship. This is very different than the other model, which is epigenetics. And so here researchers talk about biological pathways and mechanisms. And as a figure, this is another figure I used to analyze from a paper, recent review on epigenetic mechanisms. The idea is that here it's not your DNA sequence that is relevant. It is that modifications due to environmental exposures, such as methylation, that will lead you to have different levels of gene expressions that will then affect your development of asthma. So again, here you see it's a much more complex figure. It's not just a bunch of arrows pointing, and that in fact there's a constant interplay between your genetics material and the environmental factor. Although one important part here is that development is seen as requiring time. And so there is this unfolding and an emphasis on maternal environment and neonate environment. Although it is a headless disembodied woman. So again, these are these two dominant frames in asthma. So just very quickly to link this back to policy, why does this matter? Well, they vary in the assumptions made about genes, environments, and the nature of interaction and time. This means that there's a difference into who is at risk. In the first model, in the genetic predisposition plus environmental risk, you're saying that there are people who are inherently at genetic risk of asthma. Therefore, the issue is to identify those people, develop screening programs for the high risk, and intervene accordingly. In the epigenetic, environment is much more a central causal factor. It has more power in the model. And so your interest becomes and it is applicable to the population at broad rather than a high-risk stratified group. So to say that I think when we looking at the frames, I think they've demonstrated that there are differences in the claims about the translations and uses of this research, ideas about where and how we can intervene in asthma. And it also, we can maybe get into this in the discussion, identifies different interests and institutions involved. And so there's a different constellation of powers at play. Thank you very much. Thank you.
Thanks, I enjoyed those both. Just an initial question that I had for Sean, you were mentioning several kinds of worries there could be about the way these risk is set up in terms of racial categories. You mentioned the kind of sort of cost-benefit analysis, observer perspective, the sort of essentialism, the worries about truth-telling.
Yeah.
I was just curious. It seems like the cost-benefit considerations could kind of go both ways in some cases. I'm not sure if it would in the case with the Finns and the Africans who aren't U.S. born, but I can picture some cases where you say, look, it's going to kind of confuse the population if we get into too many details. I was even thinking as I was reading that discussion about hypertension, you know, the potential for people going, whoa, I can't even interpret all this list of, you know, if I'm not 51 and, you know, I've got these characteristics. And so I could picture some people saying sometimes it's helpful to just give the bigger categories and not, you know, get in as focused. And so
yeah,
I was just kind of curious if one could argue that sometimes you might say, well, from a more, I don't know, kind of rights-based framework, you might say, well, it's more, you know, it's very important to be telling the truth and to get very specific and so on, whereas the sort of more broader consequence-based focus might say, well, actually, it's better not to be as careful, you know, just give the big, broader, sloppier categories, don't confuse people, it'll be simpler. But I just wondered.
Yeah, this is sort of one of those things where it was actually my initial largest concern about the sort of like the strongest objection, and then I sort of gradually convinced myself it wasn't as important. And so the way I convinced myself that it was not sort of the biggest problem, that my sort of, it's a short presentation, so I had to think of sort of like what was like the most damning thing I could think of. And the reason why I didn't consider this to be the most sort of damning concern about like simplicity is because it's really not that much less simple. And so as I was sort of making my little slides, and it's like, well, U.S. born, that's really not that much harder. And Finnish, I mean, I don't know, somehow maybe that's a little bit harder, but it's not like it's that hard. It's like, wait, so you're saying, wait, which country was I born in? Like the Finnish one maybe, but the African immigrants, that's a pretty easily identifiable group. And so
that's why I liked your slide where you put that up and point out it's too much harder.
That's basically, yeah, that's almost how I sort of like visually convince myself that it's not as much of a concern. But I think like as this turns into a paper of some kind, and this is all sort of tentative research that I'm just starting now, but I think that is something I'll have to address. Is this something that we could sort of legitimately say like, well, simplify, and there aren't that many Finns, small country.
Yeah, I was kind of wondering if there was
something like that. Yeah.
I was going to say something about the African immigrants. I mean, from the public health research, you have stuff about, well, the Japanese used to have very low rates of, let's say, breast cancer when they first moved to the U.S., but within a generation or so, it had risen to the rate of the general population. And with Africans, it would seem like possibly within a generation or within the longer they lived in the U.S., the more they would blend into the general population characteristics. So,
yeah,
so perhaps in 10 years, this won't even count.
Yeah, so there's really not as much data about this as I would really like. But there is some data that that the effect goes down over time. Essentially, the longer you live in the United States, the worse off you are. I think it's called like acculturation to a Western lifestyle is a risk factor. But there is evidence also still though that the effect remains even after people have been in the country for so individuals who have been born elsewhere. That effect stayed even over a decade after they'd entered the United States. But then once those immigrants have children, well then they're the Obamas of the world, I guess. I mean then that's a separate category. But people who are themselves immigrants, not necessarily the children of immigrants, they are identifiable and should be, I think, sort of set up differently. Do you have a sense of?
Sure. I just wanted to quickly follow up on these two to point out that what you just admitted sounds like it makes it more complicated than saying U.S. born, because now you have to say something like U.S. born or moved to the U.S. when you were really young, or were born somewhere else but haven't lived here that long.
Yeah, and so we could sort of do the infinite more specificity forever. I think I wanted to leave it at the sort of one level more specific, partially to get away from the genetic essentialism. So basically, one swift kick in essentially the groin of genetic essentialism will pretty much take it down. And so as long as we can show that particular thing to be more complicated, then that's a good step in the right direction. Whether or not we need to have Finns from northern Finland as opposed to southern Finland, like that's where we think we sort of need to pragmatically think about how much specificity is enough. I think I'm convinced that this one extra step of specificity is justified for a variety of reasons. Beyond that, I think that's sort of another, I don't know, cost-benefit analysis, to be crude about it.
At least you have the title for your paper now.
Yes.
So, in thinking about what you're saying, Sean, in your paper, with, you know, the public can read this and then they can go into the doctor and say, well, I'm finished.
Yeah.
But now look at it from the healthcare provider's perspective, right? I mean, are they going to start memorizing all of this and then hold one standard of care for this person versus that person?
I mean, they do that now with their races. And so, it's, I mean, if you're African American and you go into the doctor, they'll start treating you quite differently, and they'll check your blood pressure and they'll monitor you more carefully. And so we've got that. Whether or not there's sort of a burden of over too much information, I think that relates to Kevin's concern, and it's a very legitimate one. But at the very least, I don't see any particular reason to actively suppress this information, or not even to consider it in the scientific discussions, let alone what's being passed along to the public. And that's one of my biggest concerns, is that this seems to be considered to be a difference that doesn't make a difference as far as the existence of these islands.
I want to jump in on it. Do you mind?
Yeah. Sorry, can we talk about your paper?
I really love the point you made about the idea that what we're actually doing is missing these really precise categories that are very easily and very readily available to us, rather than just using race as a blanket category. I think the one thing I also think this relates to Kevin's point is this idea of, well, how precise do we go, at what level of risk, what level of precision do we want? I mean, of course, is the thrust for personalized medicine is going to say until you have your individual risk, then any other risk is inaccurate on a certain level. And as an epidemiological measure, then what that is average risk in that category too, right? So there's always
there's always that other level, and it's always average of Finns.
Right.
And,
so then
and
amongst
surely
Finns, there are people with it. Right, this idea of that northern Finns, but maybe even
hypothetically, I mean, I don't even know about northern versus southern, but and so yeah, you could go forever, but I think there is something. I think I'm going to stick with the fact that I do think there's something special about complicating the racial categories themselves, because we sort of have this. As far as the degree of specificity that's demanded, there's almost a demand that population studies in the United States break down their research in terms of racial categories, and so there's a push to have that in there. But now I'm starting to see a push to have not any more than that. So it has to be exactly this level of specificity. It has to be these particular 4 to 5 races, sort of depending how you classify it, no more, no less. And that seems like a very bizarre, arbitrary decision. And I think it speaks a lot about just our general mindset or something like that about race in the United States.
Well, I think there's a sense in which Amy's distinction between the genetic predisposition and plus environmental factors versus the epigenetics can be really useful for you to make an even sort of stronger critique of this sort of like snowballing level of precision that can potentially get out of hand, and then having to make some sort of arbitrary cutoff point, because we want to avoid, obviously, making some sort of arbitrary cutoff point lest we continue to marginalize these little islands. But, I mean, potentially this is a way of thinking about incorporating the categories of race differently into healthcare service provision, because you can say that, well, okay, so we should add this next level of precision because there's evidence that these people are being excluded to their harm. But we really ought to try to design policy measures that incorporate the fact that it's not, that the policy approach thus far has been this sort of very specific environmental, genetic factors plus environmental factor approach that has been sort of linear and procedural in this respect, to the exclusion of considering the fact that environment is a huge source of risk factor.
And I'm not sure if you're familiar with Jim Taberry's work on G cross E, and I mean, he points out these examples where one's environmental background and their genetic background can essentially have reverse situations. So he uses monoamine MAOA. The genetics of that and the environment, is whether or not one's exposed to essentially domestic abuse. and it can reverse whether or not you're at more or less risk depending on your environment. And so there's something special about finding these sort of special exceptions to the, I think, that that sort of changes the ethical conversation. And so I think the islands are special. He thinks the what he calls interactive predisposition is special, where you have a reversing of whether you're high or low risk based upon your environment. And I think that sort of goes along with that diagram that you put up there, which is very helpful.
It's interesting because I mean, my curiosity comes from the policy implications. So I was trained in epidemiology, public health practice, and it was interesting to me is that public health has a particular value orientation that's not explicit. It's all implicit. And so what we're doing is research that actually may be countering public health core values when expressed as being sort of justice, or in Canada, these are the sorts of things get thrown about. You know, and what does a personalized, I've actually had one respondent say, you know, what we really want to do is we want to be able to stratify this very idea. We're going to stratify risk to such an extent that we, you know, there's too much public in public health was the language used. Too much public in public health. We need to have a more precise, and this, I mean, this is the interesting conversation between our papers and attention, because in my view, there is a problem with abandoning all universalized public health programs. So, and there's this incredible, this gene-environment interaction research has this ability to both, on the one hand, provide wonderful knowledge, detailed knowledge about the pathology that leads to asthma, and presumably that knowledge will allow us to intervene, but at the same time masks all the social factors involved and may actually be feeding information that we're going to have, I mean, so much about this leads into a conversation about pharmacogenomics.
Yes.
How are we going to identify, right? So it's
which is supposed to be sort of the sword that cuts the Gordian knot of all these things. Well, once you go into your doctor's office and they sequence your genome for $50, then they'll know what's wrong with you.
Yeah. We give two hands at the back. We have heard, yes.
Okay, so I wanted to ask you, Andrea, that when you're talking about framing, I know you're trying to get a little more specific about framing, but I wasn't quite clear. There's the kind of framing that has to do with, well, if you got different kinds of theories, or if you got two different theories, in a way they're different frames, right, ways of thinking about things. But the kind of framing, the way it comes about a lot of times in public policy debates is going back to the diversity economy, you got the same facts as a background, but you just elicit a different set of values, right? Are you more risk-seeking or risk-avoiding, right? And I wasn't quite clear sort of where you were standing on these two different ways of approaching things here, the just the simple G cross E versus the more complicated story, whether this is really, whether you're really telling a story where there's significantly different theories involved in here, or rather it's more that, well, there's an increased level of specificity and other things like that that's really about eliciting different sets of values. We're going to take it, this way of approaching things, or this way of framing things is going to let us look at different values, whereas, but at core there might be the same story to be told, right? And I'm not sure if that makes sense, but there's different theories about causal mechanisms, et cetera, et cetera, et cetera, and then there's different ways of pointing out what's important, right? That's going to elicit different kinds of policy decisions or different kinds of decision making, right? And so I was wondering if you could just get a little more specific about sort of what you think is going on.
Yeah, that's actually a great question. I think you've really hit on something that is, in some ways trying to tangle these things apart has been very, is a bit superficial, maybe, is the right way to say it. Because when interviewing researchers and, after reading their reports, there's a different type of storytelling that happens in that process. So it's a bit of both is my answer. So to some extent, I'm interested in how they measure things, why they think that's what they are measuring, why, and so disciplinary training, all these social aspects of how do they become situated, where their grant money comes from, these sorts of things all matter. Canada is a major hub, for example, and so this relates to the second part, this idea of values. It's a major hub for asthma research. And actually, asthma and allergy research on gene-environment interactions and allergy. It's called Allergen. It's received money from the federal government. It's got lots of sponsorships from pharma. And so it's a bit of both happening. Because on the one hand, it's researchers coming from their disciplinary backgrounds with their theories, with their techniques. meeting at the same time, so there's some researchers who are very politically savvy about what they're doing, and because they are marketing this research network, one of these big science projects. I don't know if that's a.
I was just going to ask about the policy implications, because that's sort of the next step from your talk about, well, if you take one model versus the other as what you're looking from, what policy do you come up with here versus the other one?
Yep.
Because that's sort of the next step there. And also, I just wanted to mention the categories of race are becoming so blurred at this point. That's a totally different question. But when you have Hispanic people marrying black people and Asian people marrying Finnish people, what happens?
As a half Tarascan, Indian, Mexican, Irish, Irish, English individual who is also now Jewish, I agree. And actually, my parents were unable to actually seek out cystic fibrosis carrier testing because my father is considered Hispanic, which means that if they wanted to actually get testing ahead of time, then they would have accuracy rates of around 70% or even less. And shortly after I was born, they suspected I had cystic fibrosis. They couldn't have known ahead of time because the racial categories had sort of, according to the racial categories they were using, the testing rates were so ineffective. And so I agree, and so does my black half brother.
Yeah, thank you for bringing me back to that. I know that got short shrift in my presentation. It's interesting to me when, from my analysis, that those who speak about gene plus E, essentially, so this idea of a high-risk genetic population, have a much more, are interested in genetic testing. They see that as something that's possible, something that's wanted, desirable, that feeds into pharmacogenomics, because that will have some sort of genetic test. Really what you hear is birth screening at birth, so that you will know, so some of the common, whether or not you should be exposed to allergens in your home. So that would be those are the policy implications, right? So what's the infrastructure that we need in the public health community to have genetic screening? We don't have the human resources, certainly not in Canada, to execute a massive population genetic screening program at birth beyond what we already do, which is very limited.
How much do you do in Canada? We do usually a few dozen things per state here. 3
is common in some provinces, okay? So it's like cystic fibrosis, PKU, and trisotomy. Someone help me out with that.
Trisomy 21,
Thank you.
Or do any other trisomies?
Yeah. And so that's kind of, we don't have, so you've got to get help. So these are the policy implications, right? You need the resources to execute this program. Where are they going to come from? And they are not just capital resources, they're human resources. There's also different ethics around it, too. So now you're saying, if you have, with the epigenetic model, what's interesting is then you might become more concerned about prenatal exposures. So now we have the issue of mothers, and policing mothers' behavior becomes an ethical issue, right? So before you're worried about identifying high-risk populations and insurance and these kinds of things that might come out, with epigenetics you get a different set of issues, right? And so the epigenetic stuff is quite early on in its development as a science, if you will. There's a lot of disparate views on how fruitful it will be. There's some sense, some people are saying this is the way, this is the only way, and others are a bit more circumspect and waiting to see how it integrates with other knowledge.
I was going to make a comment. A friend of mine at Yale who's working on asthma research, I said, so what are you coming up with? And she said, don't live near highways.
Yeah. So I was at a conference. I just want to share this anecdote. So where the research panel talking about genetics, because there's a lot of genetic research on traffic-related air pollution, right? And the idea is, the hope there is that they're going to use this information to identify those at higher risk, therefore be able to lower the threshold. But you actually had researchers in the audience come forward and ask the question to the panel. So this is like, we've established that traffic, living near airways, is probably a bad idea. Saying, how are we going to test those people and get them to move away from highways? So, but that says something about the ideological predisposition of the research community, right?
And I mean, there are historical precedents of that too. So, paper on the history of tuberculosis and reframing tuberculosis as a hereditary disease in the eugenics era. It's like, well, everybody's exposed to tuberculosis. Only the undesirables get it, and so they must have some genetic factor. And so it's G cross E, but it's mostly G, you know.
Yeah.
How are we doing on time? I think 5 minutes.
Scott was making this last point, and this may be a little bit ignorant, but I just wanted to clarify. So, would the sort of the predisposition crowd and the epigenetic crowd say agree on, say, the statistical numbers about, you know, sort of how probable you are to get asthma given this range of factors and so on? Is it the disagreement on sort of this aspect of sort of how they frame what they emphasize? So when they see, say, you know, particular combinations, the predisposition folks say, oh, well, we need to focus on the genetic factor, whereas maybe the epigenetic folks are thinking more about changing the prenatal stuff. And so is the difference between them sort of which factors they sort of zero in on and want to change? But if you actually got down to the sort of the risk numbers, they'd say, well, yeah, we kind of agree on those. I'm just trying to understand.
Yeah, no, that's a great question. So there's not a disagreement over evidence in that way, or study results, right? So it's not actually that they're saying different things. When you present them with a particular set of observations, there's not disagreement there. It's whether or not which observations should be produced. So there's a difference in the sense of how they're measuring environment. So many people are interested in a static, even a very reductionist notion of gene-environment interaction in an epidemiological sense, will not do cohort studies. In fact, they may not actually even have a control group. You know, so whereas much more of the developmental approach will want to have a cohort study so that they can follow exposure over time, because environment is seen as the critical idea of that there's life course events. So but I mean, if you it's not that there would be a disagreement in the type of analysis, and there is a lot of overlap between these two communities, right? Because in some ways one grows out of the other.
I mean, although Tabry also has a history of some of this stuff too, and he tries to make the argument there are actually multiple concepts of G cross E, and that and so he looks at R.A. Fisher, the statistician, and Lancelot Hogbin, the early developmental biologist. He says they came up with independent concepts of G cross E. So you ask a developmental biologist, what's G cross E? Well, you got a baby, and you got a fetus, and it's developing. And there's stuff going on around it. You ask a statistician like R.A. Fisher, it's like, okay, so you got a population, and you have a coefficient of inheritance here. It's like those are not the same thing, and so they agree once they know what they're talking about, I guess. But there's a lot of room for misunderstanding the possible range of views of what G cross E can mean. Yes?
I was just going to make a comment about usefulness of race as a concept in terms of policy because of things like grants. So let's say you're the Martin Luther King Health Center in South Dallas and you want to have something where you're doing more screening for hypertension or more treatment options in your health center. So you apply for a grant and you can say, well, we're black and we need this money and stuff. So in that way, it can be useful, even if, let's say, half your people are African immigrants who happen to live in the area.
I mean, it can be useful because it catches many cases. And so, I mean, like I said, like if we had race-blind sickle cell anemia screening, that would not be very good unless we replaced it with something else that would work equally well. And so there is very good reason, and also for, like you're saying, for institutional reasons. And so if we pretended these things didn't exist, then we wouldn't have special units of hospitals devoted to the health problems of African Americans. But again, there's the danger of misinterpreting that too, and so it's such a difficult balance to strike. I guess it's time for a break then. Yeah.
Thank you.
Thank you.